the organizing committee led by Mr. Rohaizam. Thank you for inviting me, and the person who contacted me, Eliana, where is she? Eliana. I disturbed Eliana 12 midnight asking questions. Thank you so much for inviting me, and thank you for having me here. So the topic that is given to me, that is not the first slide, sorry. So this is the first slide. Management of unilateral vocal cord paralysis, vocal fold paralysis. So this topic is very close to me because this is my PhD topic when I did my PhD in University College London back in 2010 to 2014. So some of you, I can see consultants, surgeons here may have listened to my lectures, but I can see many fresh faces who might not have listened to this lecture before. I can assure that for the consultant, there are a few slides that I have updated, some latest update on the implant and some about injection. So, management of unilateral vocal fold paralysis. This is the content, some introduction about recurrent laryngeal nerve injury, the natural cause, how is it like when the patient first presented and months after that, what are the treatments, and followed by conclusion. So for the recurrent laryngeal nerve injury, so many medical officers here, right? So the causes can be divided into iatrogenic, neoplastic, and idiopathic. The lecturers, examiners, they like for you to classify, categorize the way you answer. So iatrogenic, neoplastic, or idiopathic. So what does iatrogenic means? It means complication of an operation. So less common causes I have mentioned in the slides, I don't have to say it. And the commonest among of all is iatrogenic complications. And among all surgeries, the most common surgery that causes recurrent laryngeal nerve injury is thyroidectomy. So it can be either temporary or it can be permanent. According to this systematic review, the incidence of permanent vocal fold paralysis following thyroidectomy is about 2%, but it could be underestimated. When I've seen some legal cases where patient had undergone thyroidectomy and hoarseness, the surgeon just do not want to accept, they don't want to tell the patient that the patient may have been having vocal cord palsy secondary to thyroid surgery, until the patient have to find a surgeon, ENT surgeon, doctor, please examine me why my voice like this. And the surgeon said, oh my God, you have unilateral vocal cord paralysis, and the person turn out to be a lawyer who need voice a lot, and it become a legal case. Okay, so please, ENT also do thyroidectomy. General surgery also do thyroidectomy. Before you perform the surgery, you must mention about the risk of injury to the recurrent laryngeal nerve. It happens, even though if you use intraoperative nerve monitor. If you mention to the patient, you are safe. Please document it. Write on a paper, write in the medical notes. In this case, I have to go through, I have to find page by page to see which part the doctor have mentioned about risk of vocal cord palsy, which is none. Alright? So please, although it could be your bread and butter later on, when you become surgeon and you do thyroidectomy yourself, you do it every day, still you have to mention about the risk of recurrent laryngeal nerve injury. So the natural cause, okay, for those who have probably received referral from the general surgery, or maybe from the some people call them, some surgeons, breast and endocrine, or maybe you yourself, a patient developed hoarseness after thyroidectomy, acute vocal fold paralysis, unilateral, the voice is really breathy. It's a very breathy voice, okay? Because the muscle is flaccid, and that is typically a big phonatory gap. However, few weeks after that, let's say you don't do anything, the patient said, doctor, I think my voice is slightly stronger. Okay, but it's like a couple of weeks after that. That is commonly due to physiological compensation. What do I mean by physiological compensation is the opposite normal vocal folds, like trying very hard to meet up the paralyzed vocal fold to close the phonetic gap until you can see, like, can you see that the larynx like squeezing to close the gap? This is what we call physiological compensation. So I hope you're all familiar with this. Left vocal fold paralysis, right vocal fold is mobile, and during phonation you can see that everything is squeezing in. That is physiological compensatory mechanism. And after that, months after that, if the vocal fold function, mobility return, so we say this is temporary vocal fold paralysis. But if it is become permanently immobile, there are two fates of this vocal fold paralysis. The patient can continue to have improvement of voice despite immobility because the position is good for phonation. We call it favorable position of vocal fold, which due to very good regeneration and very good synkinesis, although there is no mobility. I'm going to show the video. But there is another group of patients, the vocal fold still immobile, and there is no regeneration with synkinesis at all. And the patient still have phonatory gap, and this kind of patient would struggle with their voice. So I'm going to show this video. Please have a look at this. For medical officers, which side is immobile? Right or left? Left side, isn't it? The left side is immobile. But during phonation, did you see the squeezing effect like the previous video? You didn't see that, right? And during phonation, you can see the vocal cord nicely, and you can see there is closure of phonatory gap. Can you see that? Very nice vibration of the vocal fold, closure of phonatory gap, and this patient do not have any issues with the voice. And there's no intervention being done, right? This is because the vocal fold is in favorable position, although immobile, because there is some regeneration of nerve. Okay? But with synkinesis, there's no mobility. So I cannot talk more about it because of limitation of time. So remember, the patient comes with hoarseness, and they get physiological compensation, and after that, there would, like, you have to decide whether the patient would need any surgical intervention or not. Right, now we're going to talk about the treatment of unilateral vocal fold paralysis. Alright, before I go to the treatment of unilateral vocal fold paralysis, what I have mentioned so far is mainly surgery, isn't it? As a cause of recurrent nerve injury. But there are patients who come with just history of hoarseness. Okay, I want to give you this scenario. I want to give you a scenario. A 60-year-old female complained of hoarseness for 3 months. There was no history of neck trauma, no history of intubation, no history of upper respiratory tract infection, just hoarseness. Right? And on examination, the patient has unilateral vocal fold paralysis on the left side with phonatory gap. There's no neck swelling, right? And there's no mass on the vocal cord. The patient is 60-year-old, obese, and with bilateral leg swelling. What could be the etiology of the left vocal fold paralysis? I'm sure here all medical officers, either you're already in masters or you're interested to do ENT, am I right? What could be the diagnosis? Any offer? Dr. Reem at the back would like to offer an answer to that. Dr. Reem is from Marina, Saudi Arabia. You have an answer for that? Idiopathic. Okay, what is idiopathic? With bilateral leg swelling, pedal edema until here. Sorry. Oddness syndrome. Okay, you know, pathology in the lungs, in the heart. Patient have left vocal fold paralysis. The etiology can be from the chest. Okay, someone is elderly with leg swelling and have left vocal fold paralysis. Of course, you can say idiopathic because you couldn't find things, but it should strike you in your mind that the patient may have CCF, cardiomegaly with left vocal fold paralysis. So this is very intriguing of finding the etiology of unilateral vocal fold paralysis. So now we're back to the treatment. So now, please remember the current paradigm shift in treating unilateral vocal fold paralysis is no more watch and wait for 6 months. I remember those days, like, you know, when you receive referral, unilateral vocal fold paralysis, okay, TCAC clinic 6 months, refer to speech therapist. That's Dr. Sharina, right? You used to receive many referrals from ENT, unilateral vocal fold paralysis, but now that is not the case. Okay, we treat as soon as possible. Early intervention is recommended because it gives better voice outcomes. It will prevent muscle tension dysphonia, the one, the squeezing that you have seen in the video that I've shown you. And if you give early intervention, the patient may not have to go a permanent surgical treatment, which I'm going to mention afterwards. And probably you can send the patient home without having a RAS tube feeding. For example, a patient post-thyroidectomy, a big gap with aspiration of fluid, rather than sending the patient home with RAS tube, you can give injection so that the patient can tolerate orally without having help with the tube. So what is the aim of surgical treatment? Okay, I have very little time. Is to make a firm contact between the two vocal folds, between the mobile and the paralyzed one. Okay, how can we achieve that? Is either you can inject by bulking up the paralyzed vocal fold, which is bowed and flaccid and lost volume, or you can perform type 1 thyroplasty by putting in an implant with or without arytenoid adduction, this picture, type 1 thyroplasty, or you can perform laryngeal re-innervation, non-selective re-innervation. So all of these, injection, type 1 thyroplasty, arytenoid adduction, non-selective re-innervation, the aim is all the same. You want to get the bulk, you want to improve the position of the paralyzed vocal fold so that there is a firm contact between the paralyzed and immobile vocal fold for you to produce a good voice. Right, so probably I spent a bit of time here, and then the rest I'm going to go very quickly. So for this algorithm that we have been using to treat unilateral vocal fold paralysis, you can treat as early as on table, as soon as possible. This is possible if the surgeon who is doing thyroidectomy using intraoperative nerve monitor. So any signal loss, you can inject on table. Any cuts of the nerve on table, you can do nerve repair at the same sitting. And if the patient, you don't use intraoperative nerve monitor and the patient have hoarseness, post-op, within the 6 months, you can give injection. Help the patient voice while waiting for the recovery or while waiting for the fate of the vocal fold, whether it's favorable or non-favorable. And during the chronic part, you still can perform re-innervation. This is what I meant by permanent surgical treatment. Re-innervation or type 1 thyroplasty with or without arytenoid adduction. Or if the patients, some patients are very traumatized. Like, doctor, I do not want any operation in my neck. So you can offer injection laryngoplasty with a long-term material. Right, after this we're going to very quickly remember the surgical treatment: injection, type 1 tharoplasty with or without arytenoid adduction, non-selective laryngeal reinnervation. So injection laryngoplasty, the aim is to get bulk by injecting biomaterials. It can be gel, collagen, hyaluronic acid, fat, and so on. You can read up about that. Okay, this systematic review show that if you give early injection as soon as possible, you give better outcome, and you may avoid the patient from getting to undergo permanent surgical intervention. So this is where we inject at the paraglottic space. You can see that after inject, the vocal cord is bulked up and there is firm contact between the two. These are the material you can use: hyaluronic acid for the short term and calcium hydroxyapatite for the long term. And you also can use fat, from the big tummy. Fat from the subcutaneous fat from your tummy, from the patient, not from you, from the patient. Autologous fat. Don't donate it, from the patient. So the way we do injection, you can either do transoral under dry anesthesia or percutaneous under local anesthesia. So for percutaneous, when the patient is awake, you can approach via transthyrohyoid between hyoid and thyroid cartilage, transthyroid through the thyroid cartilage, or transcricothyroid between the thyroid and cricoid cartilage, the space, right? We like to do this double band technique, right? We make a double band here, and then we have performed until now reaching 200 patients, and we published this 29 cases, because at that stage, when we have reached 100 cases, the cases that have completed follow-up and have complete data, we have about 29 cases. And it shows good voice outcome, and there was no major complications. You can read up this paper. Right, and Dr. Zuraini is here. Where is she? This is her master's dissertation. Where is Dr. Zuraini? She's there. So she have done this study, and from the double band needle, which the person who responsible bringing this to Malaysia is Dr. Masani, Prof Masani, okay, and Dr. Zuraini have done a study and shown that different gender, there is different kind of angulation of needle. So you read this paper, I don't have time to explain this. So first, for percutaneous injection laryngoplasty, upper airway anesthesia is very important. And the commonest way of giving this is by giving lignocaine 2% intratracheal. So this is giving local anesthesia at the superior thyroid notch for the thyrohyoid approach, and that one is giving through the trachea, and the patient would cough, and there is no sound. To the skin, okay, with the superior thyroid notch. Confirm that you are in the airway. Ini batuk, Okay, batuk. Batuk. So that is instilling lignocaine 2% into the trachea. The patient will cough up the local anesthesia and anesthetize the upper airway. And subsequently, the double band needle is inserted or pierced through the thyrohyoid space. Okay, you must show me the epiglottis. And then from the time, I'm going to skip this. So then, in the camera system, you would see the needle pierce through the petiole of the epiglottis, and then you direct the needle towards the side of paralysis at the paraglottic space, lateral to the vocal ligament, and augment it until you reach about 10 to 20% overcorrection. So that is injection rhinoplasty percutaneous. I am just showing you the transthyroid. There are two other ways, transthyroid and transcracothyroid I didn't show you. So now, under general anesthesia, so this video shows how we prepare the needle. Because for you, like transoral, you put direct laryngoscope using your crocodile, you need a long needle, right? So either you buy a long needle or you use a butterfly needle which you can modify. Okay, you cut the wing like so. So I think I've uploaded this on the YouTube. You can probably watch on the YouTube how we prepare the butterfly needle for the injection. And the injection can be performed either by a tubeless ventilation or by intubating the patient with a small tube, microlaryngeal tube. So I'm going to show you here the injection when the patient is given tubeless ventilation. So you can see that is the butterfly needle. You aim the injection lateral to the vocal ligament in the paraglottic space. Okay, you must show where you want to inject. And then you must see the augmentation start from inferior to superior. Okay, so observe this. Can you see that? Augmentation from inferior. I don't know whether it's clear to you or not. Can you see that? It's augmenting the vocal fold. Okay. But we have some complication with this. Okay, this is, I think one of the authors is here, Miss Norazila is here. So we have this complication where the needle goes beyond the inferior part of the vocal cord and causing this kind of swelling. We thought it was a cyst, but intraoperatively when we incised this, there was gel in there, that lasts for more than 6 months after the injection, although the patient has regained the mobility of the vocal fold. The patient had no issues, no voice issues, no breathing issues, but because looking at this and persistent, we went in, we found there's gel. So that's why recently when we went to the European Laryngological Society, Marcus Hayes have recommended when you inject, you see the 3D view of the vocal fold, to ensure that the tip of your needle wouldn't go beyond the vocal cord. Okay? For example, this is transoral. The patient is intubated with MLP and 30-degree scope is used, or you can use 70 degree. So the thing is, you want to see this ventricle, the vocal cord, and the infracaudal at one plane, the 3D plane, so that when you give the injection, you know where is the tip of your needle. See that? When you wiggle the needle, you can see the tip is here. And you start injecting, maintain the depth of the injection so that the gel wouldn't go far beyond the vocal cord. Okay, type 1 thyroplasty, live surgery tomorrow. I was told that the patient is coming. This is putting in an implant. So just now we inject gel. This one we put implants in the paraglottic space to augment and to middleize the vocal fold. This is a laryngeal framework surgery, type 1 thyroplasty, introduced by Ishiki, and these are the implants that can be used. Okay, we are going to use this tomorrow, and I'm going to say a little about this, something new, voice implant. So this is our experience using Gore-Tex middleization thyroplasty. Gore-Tex, the name, the actual name is PTFE, polytetrafluorouracil. Okay, panjangan nama. So we always call it Gore-Tex. I know the time is up. So the surgery is done under local anesthesia, or you can do under sedation. The midline is identified. and then the strap muscle is retracted laterally, and you identify the thyroid cartilage, identify the level of the vocal fold, make a window below the imaginary line, and then insert the implant. So you're going to do this on the hands-on workshop. Maybe we're going to show that in the operation room. So this is a patient undergoing thyroplasty. Okay. You can hear the patient is breathy because of a phonatory gap. And immediately after thyroplasty.
Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9.
So that is successful cases. Surgeons, speakers like to show the successful cases. But there are some complications that can occur following thyroplasty. So this is a paper published. The last author is Ramo Franco from my Sunnis teacher, and they documented about 11% complication rate. In my hand, I have experienced this kind of complication. This patient, can you see that? Big phonatory gap, left vocal fold paralysis, very small atrophic vocal fold, and big gap. After thyroplasty, no more bowing, closure of gap, but see that it's reduced amplitude, reduced mucosal wave because of over-medialization. So whenever like the implant is inserted, if it's bulged at one place, it may cause this problem. So that is one complication, over-medialization. So although voice is improved, the patient has some hoarseness. So this is another case. This normally occur in cases where the vocal fold is very atrophied. Yeah? Another one, atrophic vocal fold, big gap, and then you see this? In the enthusiasm to medialize the vocal fold, manage to medialize it, there's no more bowing, but there is some migration or extrusion of the cortex in the ventricle. I offered a revision surgery that the patient refused and want to keep the cortex as it is. So now, this is about something new, a new implant invented by this person, Guamin Ho, and manufactured in Germany. The problem with thyroplasty, that's why I said with or without arytenoid adduction, when the arytenoid is prolapsed, you have to do something for the arytenoid. But the surgery is risky of hematoma and upper airway obstruction. And this implant is claimed to be able to overcome the problem with arytenoid prolapse. Okay, so this is the implant, and you insert this, and when you inject saline through the port of the implant, can you see that? Release and then push.
So you can see the movement of the arytenoid cartilage.
So now push and release.
Yeah, so it rotates.
So the idea is you can perform this surgery under general anesthesia, and you can adjust how much you want to medialize post-operatively, or you can release some medialization post-operatively through the port that you can detect, you can palpate it on the neck, or you can use ultrasound to do it. So just a little bit on the latest advance of implants. Re-innervation is a nerve repair. I don't have much time about this. I put it last because you are not going to do the surgery, but you have to grab the concept that re-innervation is not implants, is not something that you inject, but the aim is to restore the bulk of the muscle by re-innervating the paralyzed vocal fold. And normally we need a nerve to do that. Okay, so the nerve that we commonly use is the ansa cervicalis nerve. Okay, I'm going to go through this. We call this non-selective laryngeal re-innervation, and the commonest way to do this is by performing neuropathy between a donor nerve, which is ansa cervicalis, to the injured recurrent laryngeal nerve. Okay, so ansa to recurrent laryngeal nerve repair. Or you can do end-to-end repair if you can find the proximal and distal part of the recurrent angina. And you can see in this picture, this is part of the ansa cervicalis and that one is part of the recurrent angina which is sutured together. So the idea is new axon from the ansa will grow slowly 1 millimeter a day through the recurrent angina and re-innervate the paralyzed vocal fold muscle, get back the bulk and tone and improve position of the vocal fold. Okay, so that is the what you call some principle of laryngeal re-innervation. This is some papers that I have published. I just want to show you a demonstration, one case only. We don't have time for the other case. This case is a year after total thyroidectomy, done here, but not by ENT, someone else. So that is the, he has a right vocal fold paralysis, and you can see that the gap is big, right? Can you see a big phonatory gap? And he has some squeezing effect as well. You may be able to appreciate that when you listen to this patient's voice.
Semasa saya kecil, saya tinggal di kampung bersama nenek, ayah dan mak.
So the voice is breathy because of the phonatory gap, and he has to put a lot of effort to produce voice. And this is, we have performed non-selective re-innervation and injection as well, because the re-innervation effect takes about 4 to 6 months. So this is 3 months post re-innervation, some improvement, but it is because of the gel and it's kind of wearing off the voice. The voice is better immediately after
Semasa
operation.
saya kecil, saya tinggal di kampung bersama nenek, ayah dan mak tinggal di bandar. Abang dan adik saya.
There is still some breathiness, right? But still weak. And then the gel is wearing off. And this is 4 months after re-innervation.
Semasa saya kecil, saya tinggal di kampung bersama nenek, ayah dan mak tinggal di bandar. Abang dan adik saya tinggal di bandar.
Now the re-innervation has kicked in. Okay, the thyroarytenoid muscle and the LCA now has bulked up and improved the position of the vocal fold. And his voice continued to improve until now. But unfortunately, I just saw him about 2 weeks ago. He's more than 2 years after re-innervation. The voice still good, but unfortunately, he just diagnosed to have motor neuron disease. So sad. He looks like smaller, thinner. Okay, never mind. So you can see there is closure of phonatory gap. Yeah, this is montage of a glottal cycle. Now, I don't have time to discuss about the differences. Okay, I hope you understand along the way when I give the lecture. And this is a paper that you may want to read, the differences and the comparison of the voice outcomes between re-innervation and thyroplasty. So the algorithm I've shown you already. Conclusion, there is, I hope, if you don't remember whatever I said, please remember you receive referral for unilateral vocal fold paralysis, no more watch and wait for 6 months. Refer, discuss with your specialist, do intervention as soon as possible. Okay, and the surgical intervention, unless the patient refuses, right? Then you send the patient for speech language therapies, and the options may be different according to the duration course. With that, thank you so much, and sorry for taking my time.
Thank you, Prof Marina, for the outstanding lecture. I would like to invite Ms. Zakina